Shantanu Anand, who is known all over the country as foot and ankle surgeon, and his work in this area has been tremendous. Now I would like to listen to him on Lisfranc's, which is the most difficult injury, and for a busy orthopedic surgeon, sometimes it is just an ankle sprain or a foot sprain and we don't look at it properly, and then we'll end up into problems. And then I will really have a question for you at the end of the talk. So, presenting to you Dr. Shantanu.
Thank you, sir. Thank you very much for your kind words of introduction. And it's indeed a great pleasure to present my talk in front of such an eminent audience where prominent orthopedic surgeons from all across the country have come. It's a great initiative by Corona Remedies, and I can say that I end up making a lot of good friends here this time. And for those who are probably not knowing me, I come from a place which is in Bihar, very close to Nepal and Bengal. Darjeeling is very close to my place. Sikkim is very close to my place. So all of you are welcome there. Well, the topic today is Lisfranc injury. My love affair with foot and ankle surgery started way back in 2013 when I first attended the annual conference of Indian Foot and Ankle Society, and there I was shaken out of my reverie because before that I was very unconsciously unaware of my lack of knowledge, and there I became consciously unaware of my lack of knowledge. And then I tried consciously to attain some knowledge. So maybe right now I'm in a stage of being consciously aware, and all of you know is that the ultimate knowledge is unconsciously aware. When you look at something and you just, because of your vast knowledge and experience, you know what is to be done. So well, Lisfranc injury is one such topic in foot and ankle which is really very interesting. But before I start my talk, I need a little help from my audience that will help me understand at what level I should pitch my talk. So by the raise of hand, could you please tell me how many of you have got to see maybe 10 cases in a year of Lisfranc injury? I have one. Oh, so naturally, as I said, it's a very eminent audience. And another question is, during your career at any point, have you fixed a Lisfranc injury just with K-wires? No screws, no plates, just K-wires. Because I have also ended up doing that. So I was wrong then, and I have rectified myself, and in my talk, I'll show you how just using the K-wire is not the adequate thing to do. Well, the layout of my talk is to give a brief introduction, and I'll talk about diagnosis and treatment, and thereafter I'll present one of my case where I'll also show a few videos of surgical steps. Well, this was named after York Lisfranc de Saint Marin, whose lifespan was 1717 to 1847. This Lisfranc injury, and it is the injury of the tarsometatarsal joint. Well, when I say Lisfranc injury, I'm not using the word Lisfranc fracture, mind you. It's a Lisfranc injury because it is a wide spectrum of injury. At one end of the spectrum, there are only ligamentous injury, which we sometimes tend to diagnose only as an innocuous sprain, and therefore make the patient land into trouble of having been underdiagnosed. At the other end of the spectrum, we have cases which are of frank Lisfranc. We know that it is Lisfranc, but probably we end up not doing the correct procedure, and thereby again doing less than what is required. And therefore, we must understand all the aspects of this wide spectrum from ligamentous injury to bony injury to avoid all possible complications. A little bit about the anatomy. The Lisfranc joint is formed by 5 metatarsals articulating with 3 cuneiform and the cuboid bone. And the trapezoid shape of the base of medial 3 metatarsals along with their corresponding cuneiform form the very important transverse arch of the foot, the Roman arch. Now in any Roman arch, there is a keystone at the top, and that keystone is in the shape of a wedge. If we take out the wedge, the arch will collapse. And therefore, in this Roman arch of transverse arch of foot, the second metatarsal, base of second metatarsal, acts as the keystone. So once that is gone, either due to ligamentous injury or because of bony injury, the arch will collapse and the foot will lose its normal function. And along with that bone, as I said, it's the Lisfranc ligament, which is the interosseous ligament between the C1, that is the first or the medial cuneiform, and the second metatarsal, which is the all-important ligament holding this Roman arch aloft. Well, in the diagnosis, of course, history, clinical examination, and investigation. Now here comes the key word. The key word as far as the diagnosis is concerned, and that is high index of suspicion. Just to drive my point home, I'll give you a corollary of a different case altogether, which I encountered just a few days back. Now, this is an X-ray of pelvis in an 85-year-old male who had a fall at home just 8 or 9 days back. He went and saw an orthopod, a very eminent orthopod of my city, and he diagnosed as some kind of soft tissue injury and advised just a bed rest. And let's see what happened. So, if there is hip pain, if the patient is elderly and he had a fall, he's giving a history of fall, you should have a high index of suspicion. If the X-ray is just seemingly normal, you should get a CT scan. And if you don't do that, you ending up like this, and then the patient came to me, we fix it up. So this was an example why you must have a high index of suspicion. Coming back to the topic at hand, so Lisfranc injury is one such injury where you must see all the cases of your foot sprain with high index of suspicion. And the mechanism of injury is the axial loading of hyperplantar flexed foot. And this is indirect mode of injury. And in direct mode, there could be crush injury of the foot. And in crush injury, if it is not open, many a times there is compartment syndrome. There's swelling, compartment syndrome of the foot. So in the diagram, I have shown all the possible mode and mechanism by which you can have this Lisfranc injury. Now in clinical examination, there would be, of course, if there is too much of injury, there is bony injury, there will be swelling of the midfoot or at the midfoot-forefoot junction, and another telltale sign of plantar ecchymosis. So do not forget to see the sole of the foot where you will get an ecchymosis as is shown in these pictures. Now in palpation, of course, there will be tenderness at the tarsal-metatarsal articulation. And then there is something called piano key test. Just like the keys of the piano, when you press, there is movement. So if there is an isolated TMT joint affected, the piano key test will be positive. And in certain cases, when there's too much of distraction, there will be a palpable gap, which we call as positive gap. And in long-standing cases, because of the nerves are also involved in the first Weber space, there will be altered sensitivity. An example of the plantar ecchymosis. And in the diagnosis, X-rays. Now in foot and ankle, There are regular X-rays and there are certain very specialized way of taking X-rays, which could be stress views, which could be wet-bearing views. So you take standard AP, lateral and oblique views, but do not be just satisfied with these. If the patient still have clinical signs and symptom, you employ that high index of suspicion and advise what are called as stress views and weight-bearing views. Of course, if the patient is very painful, he cannot do the weight-bearing view, but if he can, always do go ahead and take a weight-bearing view. So these are standard AP weight-bearing view, where you make the patient stand on a frame in which you can put in your X-ray plate and then take the X-ray. And standard lateral weight-bearing view. Now diagnosis, the radiological parameters. This may seem to be a very busy slide, but this is very easy to remember. First thing, the first metatarsal. So you look at the lateral border of the first metatarsal, that should be in line with the lateral border of the first cuneiform. First metatarsal, first cuneiform. Then medial border of the second metatarsal should be in line with the medial border of the second cuneiform. Third, medial lateral border of the third metatarsal should be in line with the medial and the lateral border of the third cuneiform. These three parameters in AP view, and in oblique view, the medial border of the fourth metatarsal should be in line with the medial border of the cuboid. Again, in oblique view, the fifth metatarsal should project not more than 3 to 5 millimeter from the lateral border of the cuboid. And then you do have that flex sign, which is the presence of a bony fleck, which could be a small bony fragment fractured from the base of second metatarsal in the first intermetatarsal space. And in the lateral view, the superior border of the second metatarsal should be in line with the superior border of the second cuneiform. The X-ray on this side is the normal X-ray, but there you can see it is not. So that X-ray probably should give you a strong indication that it is, of course, Lisfranc injury. Now, is there a use of CT scan? Of course there is. More than in diagnosis, it is also there in the management and planning of fixation. Both the 2D as well as the 3D, you can see in the 3D, you can see all the fracture fragments properly, which either they need to be taken out or fixed properly. MRI? Yes. Especially when the injury is only and purely ligamentous in long-standing cases. So MRI will tell you the condition of the Lisfranc ligament. Coming to treatment. There are certain concepts that we need to be familiar with when we are setting out to treat a Lisfranc injury. We need to understand the 3-column concept of the foot. Of course, classification and treatment algorithm we need to understand. Now I'll also show you the controversies, the case example, and the complication. 3-column model. There are three columns. The medial column, which is made up of the medial cuneiform, the first metatarsal, which carries most of the load while standing, the middle column. The middle column is made up of the middle and the lateral cuneiform, second and third metatarsal. Now this middle column is the least mobile, and this allows for the rigidity during push-off. Now this is the basis why, sir, a K-wire fixation is so much inadequate. We need to rigidly fix this medial column and the middle column. And that's why we need to use screws, and nowadays there are specialized plates for that. And the lateral column is the most mobile, which is used for balancing. And therefore, a K-wire fixation is just enough, which we can remove at the end of 6 to 8 to 10 weeks, so that it is still mobile and we can do the proper treatment of Lisfranc. I will not go into the classification, but it is there. A classification is an ideal classification only if it helps you in devising your treatment plan, and prognosticating the outcome of your treatment. So Hardcastle and Myerson classification is such one classification. There's another simple classification, which is Myerson's modification of the Hardcastle classification, which is simply D and DL and B, DB. So D1 is a type of injury where the distance between the first cuneiform and the second metatarsal is less than 2 millimeter. D2 is, of course, when it is more than 2 millimeter. D2L is purely ligamentous. D2B is bony. And a simple treatment plan would be for D1 not to do any kind of surgical intervention. But these D1s are very rare, few and far between. More common ones are D2 and D2B. So for D2, surgery is required. If it is purely ligamentous, you do primary arthrodesis, because ligaments are not very amenable to healing. So if you just apply a plaster or something, it will probably not heal. Your patient will end up getting complications. So it is better to go ahead and do the primary arthrodesis. But it is, if bony, you can go ahead and do osteosynthesis. Then there is another classification by Nunlo-Vertolo classification for Lisfranc ligament, which says, or which takes into account how much of distraction is there. So this also is useful for you. Now the treatment. Now the treatment goal is to restore the anatomy of the midfoot, restore the arch, so that there is no late arthritis and disability. And therefore, as I have already mentioned many a times, non-operative treatment has a very, very limited role. And non-operative treatment are to be considered only in these 4 conditions, where the injury is very minuscule, not very significant, or the condition of patient is such that it is not allowing for surgery. For all others, the treatment is surgical. So it's just a plain diagram, line diagram, which tells you how to devise your treatment plan. So if Lisfranc injury is stable and no dislocation, and if you see plantar ecchymosis, you get an X-ray done, weight-bearing X-ray, and if that reveals that it is stable, you can still go ahead with non-surgical treatment. But if weight-bearing X-ray shows that it is unstable, then again you have to see whether it is bony or ligamentous and treat accordingly. But if the Lisfranc injury is highly stable and it is very evident to begin with, then you go for surgical treatment. Now, there are a limited subset of cases where there would be very significant soft tissue swelling. Yes, there would be there. So if that is there, you cannot do primary fixation. You have to plan, which is a DSO. So for that, DCO, damage control orthopedics. For that, you just use a temporary pinning. Elevate the limb and wait for the wrinkle sign to appear. And as soon as those wrinkle signs appear, you go ahead and do the surgery. Now, what to do in surgery? As I said earlier also, a rigid internal fixation of the first, second, and third TMT joint, that is the first column and second column, are to fix rigidly, and the third column, that is the fourth and fifth metatarsals, can be fixed with K-wires. The reduction is always from medial to lateral. Now for surgery, you can use either a single incision or a double incision. I'll show where and how. The other thing, before I go into surgical thing, I mean the osteosynthesis thing, I'll also mention that sometimes you need to do only arthrodesis. And what are the indications? If it is purely ligamentous, sometime if the patient has gone undiagnosed and the patient has come to you much later, so it is a delayed case presentation, or if there is chronic deformity, and if there is complete fracture dislocation, that yes, of course, you cannot achieve an osteosynthesis. Now coming to surgical controversy. it's always a big debate in any foot and ankle meeting, sir, whether to do osteosynthesis or primary arthrodesis. The jury is still out, I'll say, because many surgeons, they still vouch for primary arthrodesis rather than osteosynthesis. But if you ask me, I'll try to do osteosynthesis in all my bony injury cases and do arthrodesis in ligamentous lesion. Now, whether to use only screws or bridge plate, the joints of the first and the second column, they are also known as non-essential joints. But nevertheless, they are joints. They have their own cartilage. And in studies, it has now been established that in long run, if we do not violate the articular cartilage, the results are better. And therefore, in those cases, the correct and the current method of fixation are plates. Now, incision. Whether to use a single incision or a dual incision, the classical approach is dual incision. But it also depends upon the size of the foot. If it is an adult, fully grown male with a, say, size 8, 9 or 10 foot, you go with dual incision. But if the foot is small, and if you give two incision, the intervening skin fold is going to be too little, then chances of that skin necrosis is high. Therefore, in such foot, you should always employ one incision. Certain cases now, fixation. But rather than these cases, I'll come to this very important thing. Now, this is what has been propagated and made very popular by my teacher, Dr. Vinod Panchbhavi of US. Initially, the screw placement, the main home run screw used to be put from the first cuneiform to the base of second metatarsal. But that was like, getting a smaller thing close to a larger thing. And the screw thread purchase used to be poor. So now, most of the time, the screw direction is retrograde, going from a smaller bone to a larger bone and fixing the base of second metatarsal to the first cuneiform. So the direction is very important. Of course, the complications could be post-traumatic arthritis, non-union, malunion, deep infection, or foot deformity. So these things are there. So take home for this talk is the timely and correct diagnosis is of paramount importance. Again, the same words, high index of suspicion. And you need to understand that injury well and devise your treatment correctly. If you're attempting osteosynthesis, anatomical reduction and correct method of fixation should be employed. If attempting arthrodesis, ensure there is union at the arthrodesis site, otherwise there will be collapse. And it is very important to communicate with the patient. Do make him gently aware of all possible complications, because chances are, sir, that in spite of your best possible treatment, the complications will occur. So forewarned is forearmed. Always make him aware of the complication. Now, with the permission of chair, and I still have time, I'll come to a case presentation. So this was one patient, a 38-year-old female, who presented to me this December only, December gone by. And here is a small video. She was taken to OT. The injury was very evident. There was a large gap as well as a flex sign, which I am showing in the X-ray. Third or fourth day, sir, if I remember correctly. Thankfully, swelling wasn't there. This is how you position your patient. I probably will be showing you the incisions here. So that is how I have marked the incision line. And here, the fracture has been opened, and you can see that's the medial cuneiform. Now the second cuneiform. And the reduction wasn't hard. We could really reduce. And in this video, you would see how correctly to clamp it. I hope it plays. Yes. So I have done the reduction and then have held the reduction with the reduction clamp, and I'm checking this in the C-arm. So that is the correct direction of your clamp application, which keeps the fracture reduced. And here, again, I'm showing you that it has been held, and I have used a plate. Now sometimes, either because of lack of availability or because cost factors, you do not get the actual plate device for it. Then you have to employ that Hindustani jugaad. So this was a mini plate which we use for fixation of metacarpals. And there it has been fixed with that plate. The two plates, you can see this is per op C-arm view at the end of completion. So you can see in this C-arm view that the home run screw has been put from base of second metatarsal to the first cuneiform, and then the plates for the second tarsometatarsal joint, again another plate for third tarsometatarsal joints, and the K-wires. The K-wires don't really have to go through the medullary canal of your fourth and fifth metatarsal. They can go this way or that way, because sometimes you can do it close also. I have opened it and I put it this way. But if they go some askew also, it is fine as long as they are holding the joint in position. So this is immediate post-op. This is follow-up. And this is the final X-ray 2 months after injury. So that was my presentation. Thank you so much, sir.
Thank you so much, Dr. Shantanu.
Thank you, sir.
Most informative talk on this topic, which is not dear to many general orthopedic surgeons, but it has been made a very interesting topic. And as you said, the take-home message is high index of suspicion.
Thank you, sir.
Whenever you see a foot injury. So we will take some questions,
Sure.
3 questions again, because of paucity of time.
Yes, sir, please.
Hello, sir. What
Sir.
is your choice of screw for home run? Is it 4 mm cancellous screw or newer screw like Herbert?
Okay, so this screw doesn't have to be a compression screw. This is a position screw, first of all. So you can have a fully threaded cancellous screw or fully threaded cortical screw as well. Herbert screw are costly. I have never employed them. And because Herbert screw will also cause a lot of compression because of differential pitch at the two ends, so Herbert screw I have never employed and probably should not be employed. Any simple screw put as a positional screw, sir. Thank you. Sir. See, sir, if it is an open injury, I'll employ the principles of treatment of open fractures. If the patient has come within, say, 24 hours, and if the skin condition is fine, I'll still go in and do a primary internal fixation, taking all the due and necessary precaution which I employ in the treatment of open fracture. So the open part of diagnosis will be taken care of as I do the treatment of open fracture. And for a Lisfranc fracture, I'll employ all the fixation methods of Lisfranc. But if it is a bad one, I'll definitely use just external fixator initially and wait for the favorable condition to appear, then only do a internal fixation, sir. Thank you.
Till date, almost 20% of the Lisfrancs are missed with conventional CT or X-ray.
Sorry, sir, come again, please.
Till date, almost 20% of the Lisfranc fracture are missed in conventional CT or X-ray. So in that case, which should be our investigational choice? Test-bearing CT or and MRI or both?
I'm really sorry, sir, I couldn't get your question.
No, what he's saying, till date, 20% of the such fractures, Lisfranc's injuries are missed.
Missed, okay.
With conventional X-rays and CT scan.
Right.
So he is asking you, what is the best investigation, correct?
In that case, which should be the best investigation?
Best investigation.
Right.
An MRI or a test-bearing CT or both?
Sir, in my practice, it's just a common sense that you employ an investigative modality which is readily available. And that's why I said that weight bearing and stress views are important. So no one investigation could be conclusive. High index of suspicion, if you are suspecting, get a specialized view X-ray done. If the patient is coming delayed, and if it is only a ligamentous injury, then probably your weight bearing X-ray will show more gap. But if even that X-ray is inconclusive, by all means, go ahead and do an MRI for purely ligamentous injury. However, if it is a bony injury, it may be very obvious either in the weight bearing X-ray or in the CT scan. Yes, sir. Sir.
You are telling about your weight bearing X-ray, it is not conclusive as such. Why you are going for MRI? Because it is stable. You are going to achieve a very good function result. Because even with weight bearing, there is no deformity. You are not able to visualize anything in the X-ray. Why you are asking a patient to going to MRI? You are not going to do anything.
No, sir, I'll answer. That's a very good question, sir, and I appreciate you asking this question. Sometime, due to pain, if the patient is still not able to weight bear properly, and your sense, your clinical sense is saying that there is still amiss, we are missing something, then it is better to get an MRI done. So it is not a strict dogma. Ye kar lo, wo kar lo, wo kar lo. The most important thing is our clinical sense, sir, and we must first and foremost rely on that, sir. Thank you.
So, last question.
Sir, please. Yes.
This is very clinical examination. Any finding suggestive of in early Lisfranc or late in Lisfranc? Some examination you have to see how to see this
Yes, sir. Yes, sir. So when I say clinical sense is nothing but all the information that you gather by history and examination. So clinical examination is part of a clinical sense, sir. And in delayed cases, if the patient is still giving you a history of pain, everything seems fine. See, a delayed case, a very apparent Lisfranc injury seldom comes as a delayed case. It is only those innocuous cases, ligamentous or just a little bit of bony fleck, that will come to you as a delayed case. So do the clinical examination, do the piano key test, also see for a positive gap, do a weight bearing X-ray. If X-ray is inconclusive, but you still see that pain is there, then you suggest MRI. So that's how you work up a case, sir. Yeah. Sir.
Take a mic, no? Please take a mic.
Sorry, it's not a pure question, it's just an answer to him. If we go by the name of the Lisfranc, he was in Napoleon's cavalry army. The actual history is when you have a fall from horse, your foot used to get entangled, and that entanglement of the foot used to give rise of.
Yes, entangle or fall on a hyperplantar flex foot.
Yes. So what was his key point is what he said. That's the thing, plantar ecchymosis.
Yeah.
He said that these plantar ecchymosis, we have a lot of foot injuries we could see, but take out a foot, see in the bottom of the foot, there is a ecchymosis. That's bound to be a Lisfranc. That's a key word. And he invented there one, the quick amputation. This Lisfranc was originally delayed because at that time there used to be vascular injuries. So this all foot has to be plantarly amputated, and with that line of this, because this is the most strongest ligament, you could amputate down.
So the last word of
So, see, in the old Lisfrancs, it is not possible to get the reduction done. So, do you advocate fixation in situ in such cases? Because the reduction may not be possible in many cases.
No, sir. Reduction is of primary importance. Otherwise, you will not achieve that transverse arch, sir. So, in situ fixation can only be done if it is being reduced by close method, which is seldom the case. So, most of the time, you need to visually inspect and make sure that the second cuneiform, the first cuneiform and the base of second metatarsal, they are in contact. That arch is there, sir. So, in situ fixation, I don't believe in that, sir.
No, especially there are 3 metatarsal basis fractures.
Sir.
And there is a dislocation.
Yeah.
And patient comes after 6 months, 8 months, when it is already malunion.
Yeah.
In such cases, what do you again osteotomize, correct this thing, etc., and do it, or?
Yes, no, in situ fixation is of no use. Most of the time, you need to arthrodesis such cases, sir.
Arthrodesis, exactly. That's
Yes.
what I'm
yes,
trying
yes,
to say.
yes.
Yeah.
That is
arthrodesis.
that is what is a general principle. You have to create those arches.
Yes, sir.
So that the foot can be a real physiological foot.
Yes.
You know, otherwise a flat foot is like a punctured tire. You know, you get a lot of energy wasted in walking. So this has been a wonderful session. I thank both the speakers, Dr. Ram Prabhu and Dr. Shantanu, and I declare the closure of this session. Thank you.
Thank you, sir. Thank you.